This is the second half of the lecture on the imaging of hearing loss. Cholesteatoma is one of the most important diagnoses that we deal with in the temporal bone. Cholesteatoma is a keratin collection. It's not actually a neoplasm because it's not cellular. It's just a ball of keratinaceous debris, but it can still have a very aggressive effect on surrounding bone and cause bone erosion without any cells inside of it. There are two types of cholesteatoma, acquired and congenital. The acquired cholesteatoma is the result of repeated infections of the middle ear. There are two parts of the tympanic membrane, a pars tensa, a tense part, and a pars flaccida, a flaccid part. Now, the pars flaccida is along the superior anterior aspect of the tympanic membrane, and it is right next to Prusack's space, which I'll show you a picture of in a moment. As the middle ear becomes inflamed, the tympanic membrane gets withdrawn into the middle ear, and the pars flaccida, because it's more flaccid, is more easily drawn into the middle ear, where it can slough off a small amount of epithelium that can produce this keratinaceous pearl of cholesteatoma, classically right in Prusack's space. The key finding that enables us to make a diagnosis of cholesteatoma, and importantly distinguish cholesteatoma from just inflammatory debris from chronic infections, is erosion of bone. Erosion of bone, the critical finding for the CT diagnosis of cholesteatoma. If the cholesteatoma does arise in Prusack's space, the most popular bone to get eroded is the scutum. That's the superior anchor of the tympanic membrane. And we'll see that on imaging. The other form of cholesteatoma is the congenital form. Rather than repeated infection, it's the result of a migration anomaly, and it can occur anywhere within the middle ear cavity. This is the classic appearance of an acquired cholesteatoma. The best way to look at this is with a coronal CT. So that's what we have here, coronal CT. Before we talk about the involved side, let's look at the normal anatomy. On the normal side, here's the external auditory canal. There's the tympanic membrane. Here's the malleus and the umbo connected to the tympanic membrane. This piece of bone here, forming the lateral wall of the epitympanum, that sharp pointed bone is called the scutum. It's a reference to shield that Roman legionaries used, the scutum. Now, the scutum and the malleus are on either side of this air pocket, the lateral aspect of the epitympanum. That air pocket is Prusack's space. Okay, Prusack's space. This little piece of the tympanic membrane is the pars flaccida right next to Prusack's space. Now let's go over to the affected side. Here is a soft tissue mass filling Prusack's space, filling the air, replacing the air that should be in Prusack's space. You see that the scutum that should be coming to a point, see how the scutum should be coming to a point on a coronal image? That scutum has been blunted. It no longer comes to a point. It has been eroded by the cholesteatoma. So a soft tissue mass arising in Prusack's space, blunting the scutum and eroding its way out into the external auditory canal. Here, classic appearance of acquired cholesteatoma. Acquired cholesteatoma can get really large, and you can see in this case the cholesteatoma has completely filled the middle ear cleft and is even eroding through the tegmen tympani into the middle cranial fossa. If you leave a cholesteatoma too long, it will erode into surrounding structures. And if you leave a cholesteatoma for too long, it will find its way all the way into the intracranial vault, where it will induce a meningitis followed by an abscess of the overlying temporal lobe. So that's why these need to be addressed. In addition to the hearing loss, this is why they need to be addressed. They will go on to form abscess in the brain. One of the important areas of erosion that we have to look for every single time we are evaluating an acquired cholesteatoma is erosion into the lateral semicircular canal. Here is the vestibule. Here is the superior semicircular canal. Here's the lateral semicircular canal. And here is Not the posterior semicircular canal, that's the basal turn of the cochlea. The posterior semicircular canal is out of plane in this coronal image. Love that question. So here is the lateral semicircular canal, and the bony covering of the lateral semicircular canal is eroded. There is a fistula between this lateral semicircular canal and potentially the middle ear cavity. Right now that fistula is plugged by the cholesteatoma, and it turns out that that keratinaceous plug is actually a pretty good barrier. One option surgically is to take out most of the cholesteatoma and leave a small layer of keratin to prevent that fistula from pouring out, from a gusher forming there, pouring out endolymph and perilymph into the middle ear cavity. An absolutely critical thing for us to identify so that the surgeon is aware and doesn't take off too much of this tumor or does so with intention. When we talk about cholesteatoma, the topic of diffusion-weighted image always comes up. To understand why diffusion-weighted image is so important in acquired cholesteatoma, you have to go back to what we used to do surgically before we used diffusion-weighted imaging. Cholesteatomas had such a high recurrence rate that patients would routinely undergo a second surgery several months after the resection to look for that recurrence and take out the recurrent disease. We call those second look surgeries. And it was routine. Every single cholesteatoma patient got one. But then we realized that these tumors restrict diffusion. And so now we can use MRI to detect these recurrences, and patients no longer have to go back routinely for a second look operation. We've obviated that second operation, and it's a huge benefit for patients. Now, here's an example case where there is material in the mastoidectomy defect, right where the cholesteatoma used to be. Is this just a little scarring? Is this or is this a recurrent cholesteatoma? Just a little bit of inflammation, recurrent cholesteatoma, some scarring? Well, we're going to use diffusion-weighted imaging here to help us out. Here is the non-echo-planar diffusion-weighted image, and you can see that this soft tissue has restricted diffusion. It's recurrent cholesteatoma. This patient needs another surgery. You'll notice that I'm emphasizing non-echo-planar diffusion-weighted image. Why would I want to use non-echo-planar diffusion-weighted image? It takes like 5 times as long to acquire the images, has slightly better resolution, but not great. Why would we spend all that extra time for non-echo-planar diffusion? Well, it turns out that echo-planar diffusion-weighted images are less sensitive than non-echo-planar diffusion-weighted images for the diagnosis of recurrent cholesteatoma, so that's why we always want to use non-echo-planar techniques in this circumstance. This is an example of the other type of cholesteatoma, the congenital cholesteatoma. This is a zoomed-in image of a coronal temporal bone CT slice. There's the scutum, and there's the malleus, and here's Prusak space. You can see that this little ball of cholesteatoma is nowhere near Prusak space because this has nothing to do with that whole recurrent infection, pars flaccida nonsense. This is an entirely independent way of getting a keratinaceous pearl in your middle ear, and these can occur anywhere within the middle ear. I like this example because it shows the congenital cholesteatoma to be somewhere near the cochlear promontory, right? It's a little anterior, but near the cochlear promontory. What do we think of when we think of the cochlear promontory? Not cholesteatoma. When we hear cochlear promontory, we think of Glomus tympanicum, right? Because Jacobson's nerve is running right over there. That's where Glomus tympanicum tumors arise. So how can you tell the difference between a congenital cholesteatoma and a Glomus tympanicum? Well, they tend to occur in different age groups, but there is some overlap. And this can be very confusing to a radiologist. And then our otologist colleagues laugh at us because a Glomus tympanicum is red and a cholesteatoma is white. And so if you're ever confused between those two diagnoses, just call up the otologist and say, well, what color is this thing? And you'll have your answer. Here's another example of a Glomus tympanicum tumor. This one perhaps a little more characteristically filling out the hypotympanum, and you can see how as it grows it can erode into surrounding bone, as paragangliomas usually do. and it can interfere with the ossicles. Glomus tympanicum, one of the 4 types of paragangliomas that we encounter in the head and neck. Here's those 2 images side by side. Thanks again, Jane. The congenital cholesteatoma just anterior to the cochlear promontory, the glomus tympanicum right on top of the cochlear promontory there. Very similar appearance, mimics, but easy to distinguish clinically. While we're talking about conductive hearing loss, I will again mention middle ear cholesterol granuloma, clinically referred to as a chocolate cyst. This is a cholesterol granuloma that forms in the middle ear cavity, enlarges the middle ear, and gives it a more spherical configuration. The critical finding is bright signal on T1, bright signal on T2 in an expanded middle ear cavity, just as we talked about in the previous lecture. Resorptive osteitis of the incus is a very subtle diagnosis. If you are not looking for this, you will not see it. It turns out that the incus has the most tenuous blood supply of the ossicles, and if anything happens to diminish blood flow, the incus may resorb and atrophy. You're going to see this on a coronal image like this one. Here's a coronal image in a normal patient. You can see the long process of the incus coming down. You can see the head of the stapes coming out, and there's our incutostapedial joint right there. That's what it's supposed to look like. Here is a patient with resorptive osteitis of the incus. Here is the body of the incus. The short process is missing. There's nothing coming up to meet the stapes, and in fact, it's displaced slightly. It's fallen slightly inferiorly because it no longer has that support from the incutostapedial joint. So this little line right here is missing over here. That is resorptive osteitis of the incus as a result of ischemia to the incus itself. Here's the same thing seen in the axial plane. The incus is lacking its posterior elements. The stapes is still visible. The crura of the stapes are visible, but there's just nothing in between the incus and the stapes. The third type of hearing loss we're going to talk about is mixed hearing loss. Now, I've heard some people say, well, when I see a patient with mixed hearing loss, I'm just going to look for all the causes of sensorineural hearing loss and all the causes of conductive hearing loss, and there, I've covered mixed hearing loss. But there are some diagnoses that are specific to mixed hearing loss, and when you see that history, you've really got to look carefully because these can be very subtle diagnoses. Chief among these is otosclerosis. Otosclerosis is an infiltrative disease of the temporal bone itself that has 2 components. It has a lytic component that affects the otic capsule, the densest bone in the body, and makes it less dense. And it has a sclerotic component that is sclerosis of the stapes footplate or oval window. Otosclerosis is named for that sclerotic component. Unfortunately, on radiology, it looks like a lytic process, which has led some radiologists to prefer the term otospongiosis. I haven't really seen that used as much in the surgical literature, so to maintain communication with my surgical colleagues, I continue to refer to this as otosclerosis. Otosclerosis comes in 2 forms, a cochlear form and a fenestral form. The fenestral form always comes first, and we'll talk about how to find that. And then the more advanced version of otosclerosis is the cochlear form. There are several diseases that can mimic otosclerosis, including otosyphilis, although we don't see a lot of tertiary syphilis in my part of the world. Osteogenesis imperfecta, a rare diagnosis. Paget's disease, which, although not rare, is rare in the temporal bone, and fibrous dysplasia. And we'll talk about how to distinguish those. The fenestral form of otosclerosis is very subtle. To understand where to look, you need to understand the anatomy of the fistula antifenestrum. So here on this axial image is the cochlea and the vestibule, and there is a little triangle of bone in between the cochlea and the vestibule. Through that little triangle of bone runs the fistula antifenestrum. This little fistula is so small you can't even see it on CT, but we still call this the region of the fistula antifenestrum because it's right in front, antifenestrum because it's right in front of the oval window. This triangle of bone should be the exact same density as the rest of the otic capsule. But you see in this case, the otic capsule comes around, and becomes more lytic in the region of the fistula antifenestrum. That is Fenestral Otosclerosis. This is really subtle. If you are not looking for this, there's no way you're going to find the Fenestral Otosclerosis. That's why when you see the history of mixed hearing loss, it should trigger this in your mind, and you should look specifically for Fenestral Otosclerosis. Just another example. You can't see too many examples of this difficult disease. Here is this triangle of bone right here. Here is the region of the fistula antifenestrum. Should be the same color as the rest of the otic capsule, but you see this vague area of lower density. That is otosclerosis. In cochlear otosclerosis, there is a halo of spongiotic bone all the way around the cochlea itself. And you can see this line right here going all the way around the cochlea. That should be super dense otic capsule all the way around there, and instead it's become spongiotic and more lucent. There's our cochlear form of otosclerosis. This is essentially always preceded by fenestral otosclerosis. Remember that there's another component to otosclerosis. It's not all about the spongiotic bone in the otic capsule. There's also a sclerosis that occurs. Here is the oval window. That should be just a straight transition from gas to liquid across the oval window, across the stapes footplate, but instead you see there's this bony bridge across the stapes footplate. This is an extreme form because this is a severe disease because I wanted you to be able to see it. But that's the sclerosis component that gives otosclerosis its name. In patients who have otosclerosis, you'll often see a stapes implant. Remember that there are two ways that otosclerosis causes hearing loss. One is this infiltrative component in the temporal bone, in the otic capsule, that causes the sensorineural hearing loss, and the other is the sclerosis of the stapes footplate that causes the conductive hearing loss. Patients who have otosclerosis will first be treated with removal of the sclerotic tissue across the oval window, open up the oval window and put in a stapes implant. This will correct the conductive component of the hearing loss and can buy this patient another 10 years of pretty good hearing before inevitably they require a cochlear implant to address the sensorineural component of their hearing loss. But when they're in between those two surgeries, you'll often see them with the stapes implant and still be asked to assess the severity or progression of their disease. You can see otosclerosis on MRI, although CT is the preferred way to image it. It appears as circumferential inflammation enhancement around the entire otic capsule. Occasionally, otosclerosis occurs in some weird locations. It can produce divots on either side of the internal auditory canal, and then there's this classic appearance of Ossicular Otosclerosis. A very rare disease, but you can see that same spongiotic bone that we were talking about in the region of the fistula antifenestrum, this time affecting the incus, right, and enlarging it and making it somewhat more lucent. A rare diagnosis, Ossicular Otosclerosis. Be careful about partial volume averaging mimicking otosclerosis. Make sure that you're in the center of the region of the fistula antifenestrum and that you're seeing the entirety of this triangle of bone, because just below this is soft tissue of the vestibule and the middle ear cavity, and so it's very easy to get a partial volume and make it look as though there is some lucency there when really the region of the fistula antifenestrum is intact and just as dense as the rest of the temporal, the rest of the otic capsule. There are some diseases that are classic mimics of otosclerosis. Perhaps the best known one is Osteogenesis Imperfecta. When OI affects the temporal bones, it causes lucency throughout the otic capsule. And you can see this halo of lucent bone surrounding the cochlea looks just like otosclerosis. Usually there's a sufficient history that you're not going to be fooled into thinking that this is otosclerosis. But know that this is an expected part of osteogenesis imperfecta. Paget's disease can also affect the temporal bone, although it more commonly affects the calvarium. When it does so, you see loss of the differentiation between the cortical and medullary bone, and you can see lucency infiltrating across the petrous apex and involving the otic capsule, and particularly this area of the fistula antifenestrum you can see is abnormally lucent, much like the fenestral form of otosclerosis. It is rare for just that area to be involved in Paget's disease. Usually the skull is extensively involved by the time the temporal bone becomes involved, so that's a useful clue. This is a pretty classic appearance for fibrous dysplasia. Fibrous dysplasia should spare the otic capsule. So although we'll see a lot of lucent bone all the way around and some classic ground glass appearance here, although we see lucent bone all the way around, the otic capsule itself should remain spared in fibrous dysplasia. This is a differentiating feature between fibrous dysplasia and Paget's disease of the temporal bone. Going back again to these comparison cases, here is otosclerosis, cochlear form with this halo surrounding the cochlea. Here is osteogenesis imperfecta, also with a halo around the cochlea. Obviously, patients with osteogenesis imperfecta have a long history indicating their diagnosis. And that concludes our review of the imaging of hearing loss.